Hello everyone, my name is Yoon Kim. I came from Korea Institute of Oriental Medicine, and today I'm gonna present my recent research about the somatotopically specific primary somatosensory connectivity to Salience and default mode network encode clinical pain. So let me start with introducing functional connectivity. Earlier, Professor Richard Harris and Jane Kong showed some connectivity result, but I want to help you what is functional connectivity is. So, human brain represents 2% of overall body weight, yet it consumes consumes 20% of total energy when it is not performing any kind of a particular task. So, researchers curious about brain function at rest, even though there is no specific particular task. So, brain researchers usually explore some response during task or response to pain or external stimuli, but resting state is there is no particular task at all. So, resting state network means basically we take a look at brain functions at during rest. So they found a set of brain regions show similarity in their fMRI signals. So as you can see in the figures, this is posterior cingulate cortex, and this is medial prefrontal cortex. So we pull out the fMRI signal from these two distinct brain regions, and we found that these two different regions showed really similar fMRI signal patterns. So people think even though there is no task, our brain inherently organized and doing some common functions. So multiple studies have demonstrated altered functional brain connectivity in numerous neuropathic or functional pain disorders, including increased or decreased cross-network connectivity between these several resting state networks. Let me introduce the most popular functional network, the functional connectivity network. So this is default mode network and Salience network and sensorimotor. So in perspective of pain, default mode network is involved in processing of afference of pain dimension, and Salience network is associated with re-allocation of resources toward to the silent stimuli such as pain. And also sensorimotor network has shown S1 is the critical, S1 is one of the main region of sensorimotor network, and S1 is known to process one of the critical component of nociceptive pathway, and is known to receive and process afference of nociceptive stimuli. So people usually, mostly these three networks, cross-network connectivity was evaluated in chronic pain population. So this is my prior the research result. So resting connectivity is also altered by sustained experimental pain in health control. So we have, 20-ish health control, and we delivered some pressure pain for 6 minutes, and we compared connectivity during rest and this sustained pain state. So what we found is that sensorimotor network connectivity was decreased during this pain condition, which is this area. So this is a representation of S1 area. And as you can see, this is area of representation of leg area. And we also found the Salience network connectivity was increased to this similar leg area during they have some like sustained pain stimulation. So this is most like functional connectivity can have some property of like a state-like property. So we hypothesize that the location of chronic and clinical pain is an important feature in brain plasticity in chronic pain, and that both location and intensity are encoded by connectivity between somatotopically specific S1 and brain networks. So our research question is that both location and intensity of chronic clinical pain encoded by functional connectivity, and there is a functional brain connectivity ascribed by both trait and state properties of pain. So this is our study population is chronic low back pain patient. So we included subjects were included in the idiopathic chronic back pain, and the patient was confirmed by the study physicians, and the duration of low back pain greater than 6 months, and also severity of low back pain averaging at least 4 on a 1 to 10 pain scale. We excluded some subjects who has some back pain due to like cancer, fracture, infection, or like a mechanical instability, or patient who has some radicular pain below the knee. And we also exclude patient complicated chronic back syndrome, and we also controlled their drug usage. So actually for this study, to experimentally manipulate their clinical pain state, we test the stability of cross-network connectivity. We adopted a modified version of our model for clinical back pain exacerbation. So we then explored the association between altered connectivity and exacerbation-induced changes in clinical pain intensity. So physical maneuver is kind of like back-targeted physical maneuvers, and so this maneuver was individually determined, and sometimes patient who was unable to increase their back pain by our suggested physical maneuver, then they just choose the experience from their daily lives, then that can exacerbate their pain. So this is our study design. So we have like more than 100 chronic back pain patients, and we have also compare group as a control, the healthy control. So low back pain patient was randomized to either Barham, sham, McRager, and user care group. But I apologize to you in this room to who expect hear about some like acupuncture or interventional like research result. But today I'm just going to show some data from the baseline. So I'm still working on my data analysis for longitudinal research. So hopefully next ICMART meeting I can be invited and can show some result. Okay. So let me just give some more explanation about our MRI session. So at baseline, so we have 127 low back pain patients, and we scan their resting state fMRI, and we have them perform some physical maneuvers like toe touching and pelvic twists or something like that. And we take them out, then have them perform some physical maneuvers, and then we put them into the scanner again, then scanned one more time resting state functional MRI. And we have his control, so please note that we didn't have his control to perform the physical maneuver. So this is our just resting state fMRI data. We use like just technical things. Okay, so this is our clinical measures. So we have some self-reported assessment. So we have like as a primary outcome, we have low back pain bothersomness, and we also have back pain, back displacement inventory scores, and back pain specific disability score, and pain reported outcomes measurement information system scale, and also we have questionnaire for pain catastrophizing scale. So this is the result. So by using our physical maneuver, so we can increase their low back pain significantly and robustly. So as you can see here, so before physical maneuver, their pain was like near 25, and after physical maneuver, they have like pain around like 50 out of 100. And some of them, most low back pain patients could increase their pain, but some of them are not. So this is your brain result. So we found increased Salience network connectivity to S1 back in chronic low back pain patient compared to his control. So as you can see, the Salience network was negatively correlated with this S1 area, but after in his control, and chronic pain patients show like some positive correlation between Salience network to this area. And after, when you compare his control to chronic pain patient after following the physical maneuver, this result got further increased connectivity, showed increased connectivity. So this area is, we can say, this is again the homunculus of sensorimotor area. So this is like a trunk area, which we can say this is back area, and this is exactly the somatotopically specific S1 for back representation. And we also found S1, so we tried to ROI analysis, and we took that S1 area as our seed, and we found increased S1 back connectivity to Salience network in chronic pain patient. So this is also, so this is our seed for representation of back area, and we found some anterior insula connectivity and anterior TPJ area, those are core brain regions of Salience network. So we also do some correlation analysis to more closely link changes in functional brain connectivity with clinical pain intensity. We performed the whole brain linear correlation analysis, and we found maneuvers induce changes in S1 back connectivity to anterior insula was correlated with changes in clinical pain. So what that means is, so subject who showed greater pain increase after physical maneuver showed greater increased connectivity between S1 back to anterior insula. And we also take a look at the default mode network connectivity, and we found we found some like correlation between changes in default mode network connectivity to S1 area. I can say this is again back area, and following the maneuvers was correlated with the clinical pain change. So greater back pain, the subject who had more pain after clinical maneuver showed greater decreased connectivity between default mode network and S1 area. So we have like 127 low back pain patients. So we tried to subgroup analysis with show high pain catastrophizing scores, which means show some negative affective negative affection of the pain. So we found that default mode network connectivity change was correlated with the changes in pain. So again, the greater clinical pain increased patient showed greater changes in default mode network connectivity to this anterior insula. So to summarize, so we evaluated a large sample of low back pain patient, and we found compared to its control, patient demonstrated increased S1 back connectivity to both Salience network and default mode network. And pain exacerbation maneuvers increased S1 back connectivity to Salience network regions, but decreased connectivity to default mode network with greater pain intensity, increased linked with greater shift in these connectivity patterns. So default mode network connectivity was increased to Salience network node, which is anterior and / middle insular cortex, which was correlated with the magnitude of increased clinical pain following physical maneuvers. So this result was consistent to our prior findings of increased default mode network anterior insular cortex connectivity in chronic population in fibromyalgia and also low back pain population. So to conclude, so we found, based on our findings, increased information transfer between somatotopically specific S1, which is back area, and the Salience network regions, particularly anterior insular, likely plays an important role in re-allocation attentional focus and affective coding of somatic nociceptive afference from specific body area. Increased information transfer between anterior insula and default mode network in chronic low back pain patient, and its association with clinical pain was strongly influenced by pain catastrophizing. Okay, so before I finish, let me thank to our team. So this is a huge project team. So I want to highlight this Martino Center for Biomedical Center in USA. So here is Jian Kong, Dr. Jian Kong is here. This is the Martino Center team, and we have Brigham and Women's Hospital in Boston and Pittsburgh, and also Keon. Thank you very much.